Development, which is one of the governmental French institutions like CNRS, maybe people knows, which is well known, and INSERM in France. And now I am based in Laos, researching in Laos, starting new research project in Laos. But I did my PhD in India, and then I conducted research here in postdoc during 4 years, and mostly on anthropology of reproduction. And so it is one part of this research I would like to present to you tonight. I don't know how long I will speak. If it is too long, maybe I will cut. I don't know. I just check the time. Maybe 45 minutes, and then we can have questions. I'm sorry, as it's in English, I will be quite near to my text because I am not able to speak like that in English. So, but if there is something which is not so clear for you, feel free to interrupt with our small group. So I think we can do that. So, and I want to talk especially on the local interpretation of the global health agenda and focusing on maternal mortality program in agenda in Cambodia. Alors, contrary to, I did the slide with many texts because sometimes we have many students from the university coming here who are not so easy with the English. That's why it's very didactic and scholar, and I guess that you will not need that, but in case. Contrary to animals, human females have the most problem in giving birth as they have effectively a small pelvic outlet and bear infants having a large head. When nothing is done to avoid the maternal mortality, in fact, the maternal death, natural mortality is estimated at 2.500 for 1,100 live births. As a part of the world, the level of maternal mortality is about 5 for 100,000 live births. In other parts of the world, it's very high. And since decades, maternal mortality has mobilized various fields of expertise and leads to produce what we call in anthropology the social forms, identities, and what we will see may be the boundaries of human. And in fact, using this lens of the social forms, I want to revisit my investigation related to birth control and maternal reduction program in Cambodia and examine how the interpretation of the global agenda are made locally. And in fact, my interest for maternal mortality is not new, as before to be a researcher, I have been involved during quite 10 years in the field of public health and humanitarian action in Asia, in Africa, in coordinating maternal reduction program. And then I did I restart studies and I did my PhD in southern India on birth issues. And then in Cambodia, it is the 3 research projects I work on, and it was one of the projects related to the cultural dimension of hygiene, and I focus mainly on reproductive issues in that. Then I work also in another project which was to document the reproductive issues of women living with HIVs, and I document also women reproductive health issues among women living with HIV involved in clinical trial with Pasteur Institute. And my last project was about the abortive pill here in Cambodia. I work both of illegal abortive and later on the metabon, the legal abortive pill. So, and on that, I collect a lot of information, hundreds interview, observation in different settings, and mostly in Phnom-Penh suburb, in some health institution, and in the province of Sphairing and Takeo. And I work, what I wanted to do, I work both in a health setting system, but also I visit many women, follow them at home, and women working in the different settings, like in factories, in small shop, in karaoke, and I document many things related to cross the different point of view related to the stakeholders, the caregivers, and the users in the field of the reproductive health. So, and what I want to explore here is the various domains related to what we call the social construction and the social production of reproductive bodies, and try to reflect on the inner relation in between the development expertise ideologies and the practice, and their local embodiment and their interpretation. So my aim is to see how, what, and to what extent the technology and the social form of the medical intervention mobilized in the field of maternal mortality reduction tell us about the articulation of citizenship, identities, and biomedical technology. Just for a word which may be not so clear for you, is this biomedicine and biomedical that I will use, which is used in anthropology of health to define what the biomedical system is. The Western system of medicine. That means is the medical system of medicine that focus is practice and development of technology only on the biological dimension of health and the biological dimension of the human. It is what we call the biomedical system and biomedicine. So I will speak first with the maternal mortality as bio-inequality, and then the social construction, how it came out that the maternal mortality became a public health problem. And then I would like to give two examples on here in Cambodia on vasectomy and on abortion procedure, and then I will see how we can go further beyond these ethnographies and to see what came out related to the object to document the social form and the articulation of this citizenship, identities, and biomedical technology. So first, 20 years ago, so I give the theoretical frame of my discourse. 20 years ago, Feynman and Jansen document how the global interdependence of health determinant entails that any mortality and morbidity rates found locally is at least partly the result of political and economic interrelation. Following this view, Fassin also examined how widely health become the subject of concern for states and an issue of negotiation and conflict between international, national, and local institutions. He states that health is an object of public concern as well as a shared expression of the recognition of health as a principle of legitimacy. He argued that the imposition of bio-legitimacy, which is the power over life, that has become a crucial issue for the moral economies of contemporary society and the generalized mode of governing. How health issues will determine many actions who are done in societies, and how health is becoming the point of entry in doing something somewhere. The imposition of bio-legitimacy results also in deciding the sort of life people, the sort of people that may or not, or that may life or not life, and that it leads to define what is called the bio-inequality. So, I would like to build on that to see what shapes the maternal reduction program historically. According to the recent estimate in 2010, the global maternal mortality ratio was estimated at 210 maternal deaths for 100,000 live births. Sub-Saharan Africa has the highest ratio, and these health indicators as maternal mortality represent the biggest discrepancies between the rich, middle, and low settings countries. And many initiatives have been undertaken in this field by various sectors, institutions like the World Health Organization, the United Nations through UNICEF and UNFPA and World Bank. The cause of maternal mortality and the efficient strategy to reduce it are well known since over half of century now. But nevertheless, in most of limited resource settings, maternal mortality is still very high. So, what has been documented in Europe and the United States, for example, is that the reduction of maternal mortality program has been possible by various means. Indeed, the early awareness of the magnitude of the problem, the recognition of the avoidability of maternal death, and the mobilization of professionals have had a great impact on reducing the maternal mortality in northern countries. But in addition to that, the biomedical discoveries related to hygiene control, antibiotherapy, but also economic and social development, nutrition, sanitation improvement have known as a significant factors that contribute to improve women and infant health. In southern countries, things happen quite differently. So I want to document now the social contributions of maternal mortality as a public health problem, on how it was put on the international agenda. Since 1958, 10 years after the WHO was created, various factors have shaped maternal mortality as both a public health program and a problem and political priorities. In the first half of the 20th century, indeed, little attention was given to maternal health internationally. Most tropical medicine or international efforts were oriented around war and trade and around the protective measure applied to colonizing population and its workforce. And effectively, for example, in colonial Cambodia, the first program were targeting about mostly the plague, the vaccination, and very few concern was given on maternal health. And the first issue, for example, in Cambodia, with the first action was to protect the militaries who were dying because of the relation that the military had and contracting many sexually transmitted disease like the syphilis, etc. So many contingents were dying of problems related to MST, and it was the reason why gradually in the colonial Cambodia some program came out to target the reproductive health of women, and first the reproductive health of women who had sex with the colonizer. Yeah. So it's not so recent actually. So in 1958, so it was the first time that the maternal and child health was identified as an area of action, and effectively that was very much influenced, particularly in the 1970s, by the family planning movement. And but in the years 1974, the first maternal health strategies that prioritized the family planning as a way to improve maternal health. So it was only the birth control method and issues who was discussed on that moment. But also in the international women health movement emerged in the North countries and started global campaign for women's rights and advocated for women health issues to be added in the agenda of the donors agencies. And it was in this context that the first demand came around for abortion services on that time. And finally, in 1985, Rosenfield and May wrote an influential paper and put the issues of maternal mortality on the international health policy. So then there was the first conference in 1988 in Nairobi, which was sponsored by the World Bank, WHO, and FPA. And it was only in the mid-1990s that international actors funded large-scale programmatic activities. So, in southern countries, contrary to what has been documented in the United States and Europe, various institutions, local, international organizations, networks, community-based organizations have emerged to tackle maternal mortality while focusing only on its biological dimension and mobilizing mainly biomedical intervention strategies, ideologies, technologies that I will refer here as biomedical things. Furthermore, those programs are implemented within context that combines private care, government program, short-term planning, pressurized in many cases also by international monetary funds, World Bank, structural adjustment program. So the context is very different. Currently, various factors have shaped maternal mortality as political priority, and because now there is, the issue was to deploy some evidence to show to policymakers that the problem exists, and this, and with many other things, but I have no time to develop here, had contributed to launch what I think that most of people know here, that the Millennium Development Program goal, the MDG, and the MDG 5 initiative, it aimed to reduce the maternal mortality by 3/4 in 2015, quite in 2 years. MDG's 5 program implementation offers a sensitive lens to observe the intertreatment of global health and biotechnology within societies. And so the purpose here is to document what's up in Cambodia. Ça va revenir, revient à la vie, c'est ça? Alors, in Cambodia, various international and local institutions, organizations, and scientific research pilot programs have been funded in the field of maternal mortality reduction. And in Cambodia, as elsewhere, new individualities appear as international experts, trained primary, secondary midwives, trained traditional birth attendants, for example, whose mandates are to provide services for women to decrease this maternal mortality, and many roles, social roles, has appeared as the abortive, safe abortion provider, the abortive pill seller, the vasectomy motivators, the birth control counselor have been created. And new biotechnologies have been launched, the safe delivery kits, the maternal manual vacuum extractors, the abortive pill, the sterilization procedures. And so in those contexts, the poor woman living in southern countries has been defined as the beneficiaries and mostly seen as reproductive bodies whose life and procreative products need to be safe. Since the end of the Khmer Rouge regime, Cambodia is the poorest country that receives each year more than the budget of the state from the UN and from various public and private donors. The governmental counterparts are supposed to use those $1 million to strengthen the health system. However, it is not so easy, as you know, and various social determinants, as the lack of transparencies in program implementation, but also short-term program, multiplicity of interlocutors and strategy, the remaining poverty are a great eminent barrier to health access. Alors, in the policy of Cambodia, we have now the Health Strategic Plan 2008-2015, within specific action to reduce the maternal mortality. And effectively, many actions have been done in this field, like the code of ethic of midwife has been set up, many services have been implemented, and effectively the maternal mortality ratio has fell from 472 per 100,000 live births in 2000-2005 to now, with the last figures, 206 deaths for 100,000 live births. So many progress are done effectively. And among this strategy, I want to speak on two programs in particular. First, the vasectomy program, and then I will speak about abortion issues. And thirdly, I would like to describe particularly how the MDG 5 are implemented in the most deserved area and settings in Cambodia. Alors, create the agent of positive change, the vasectomy. The vasectomy is a permanent method of male sterilization. From 1970s, this method has been promoted by feminists and scientists as a birth spacing equal sharing of responsibilities in the field of reproductive health. Vasectomy was almost non-existent in Cambodia until 2000, since it has been promoted by some NGOs. From the public health perspective, vasectomy method is described as a cost-effective technology. Indeed, the monthly number of vasectomy cases has a considerable impact to increase what is called the CPR, the contraceptive prevalence rate, which is a figure very important to show about the effectiveness of program. The CPR is one of the main indicators used by donors in order to measure that program cost effectiveness in this field. Mostly, what I have observed is that two strategies are implemented. The first one is organization of free vasectomy camp in some health structures. People can come, and someday there is promotion and it's free. Sometimes they have reduction program. There is advertisement, so the men can come and get vasectomy. Another method is based on regular community motivation activities. If some of middle and upper class men go for vasectomy, what I have observed is that in poor settings where I investigate, in suburb of Phnom-Penh, but also in countryside, it seems that it is not so much simple things. Alors, when I did the fieldwork, I meet two kinds of men: the vasectomy motivators, which are supposed to recruit candidates for vasectomy, and those who undergone the surgical procedure. While discussing with couples in this area, discussants pointed out factors that steer them to seek a permanent family method, mainly related to economical and health issues. People effectively mention their economical difficulty to feed, educate their children, the cost of abortion care when facing unwanted pregnancies. They also raise various questions related to the fear of complicated delivery, and effectively they were very much interested to have a permanent method. But vasectomy is also described as cryo. It is a Khmer word used to design cut penis or dyed penis. Such means are used in rural areas in order to sterilize dogs or to obtain the pig rapid growth. The fear to have less physical power and labor force, and the dread to become more violent and aggressive, as was often mentioned by my informants. And for interviewed people, for example, quote, the sexual life won't be the same, their penis won't erect as usually, after vasectomy it will be dyed. So in such context, intensive information and communication programs were launched in targeted areas in order to clarify the misconception surrounding vasectomy. Nevertheless, it appeared quite impossible for motivators to find out vasectomy candidates. Thus, the implemented strategy was to identify couples who were interested to undergo permanent family planning method. The day the couple arrived in the clinic, both woman and husband, for tubal ligation, because people thought that this permanent method will be for the woman, it will be tubal ligation, they assisted to a persuasive counseling session whose main objective was to present the vasectomy advantage in terms of time consuming, cost effectiveness and safety. Arguments to the observed sexual capacity improvement were also given. If you got vasectomy, you will receive, will be so good and after, and if you save some money, because if your wife go for tubal ligation, she has to stay someday, she will not able to work, etc. If you get vasectomy, in 10 minutes it's done, and the day after you can work. So it was really the message which was given. And in such circumstance, and considering also the social distance in between caregivers and patients, more than 90% of couples, according to the figures that the organization told me, accept the vasectomy in this context. But no delay was given to the couple to think about this proposition, and the vasectomy procedure was done immediately after the counseling session. When following those cases after some time at home, what came out? It came out that effectively vasectomy had some time a greater impact on the sexual life of people. They mentioned that they didn't need to sleep separately anymore to avoid pregnancy. They have often sex and they experience more desire and pleasure. More often, people mention that the issues surrounding reproductive health, and this explains that because of vasectomy, they spend less money on reproductive health care. So they have the opportunity to save money. I have a quote somewhere, but I think I'm using too much time. So for the vasectomy motivator, what came out? Mostly, the vasectomy motivator was young men, unmarried, who did not undergo vasectomy. To recruit candidates for their vasectomy, so was a very difficult task for them, and it was not the case only for one colleague of them who was elder. And he told this vasectomy man, he said, the priority reason was to be a model for other men. In fact, I got vasectomy surgery 1 week after I worked with the organization. I decided to do it as reference. If you don't have any reference, then you just go to the village, you persuade villagers about vasectomy, but they won't come for surgery because they were confused that after surgery their sexual life is finished. But when our team tell about me, many couples agree. As a result, this year I get many cases of vasectomy. So we have these two kinds, this vasectomy motivator and the vasectomy men who undergo the procedure, sometimes in quite coercive way to deal with the reproductive issues. So the second part of my talk is about abortion issue, which is, as you will see, a big issue in the maternal reduction program. Effectively, unsafe abortion is still recognized as a leading cause of maternal mortality and morbidity. Alors, following the International Conference on Population in Cairo in 1994 and its recommendation in terms of unsafe abortion limitation, various organizations involved in the field of reproductive health launched activities to provide prevention and post-abortion care. In Cambodia, the abortion law was reformed in 1997, and this allowed abortion on request through 12 weeks of pregnancies and in certain consents during the second trimester. Nevertheless, liberal abortion law does not guarantee that women can obtain safe abortion services. In 2007, 10 years after the law promulgation, the scarcity of safe and affordable abortion services was very much observed. Various people or organizations have been struggling for years, and it's only in 2010 that some action were launched. Midwives, doctors were trained to provide manual vacuum extraction. Biomedical material has been supplied. So how we can explain about that delay? Why the delay was so important, and why abortion is still a sensitive issue in Cambodia? Alors, there is one issue. Effectively, from variety of textual sources, abortion has been severely disapproved in the Buddhism tradition, especially in the ancient Theravada text. Even if there are various discussions on this in the Buddhist milieu that I will not mention here, it is generally assumed that abortion stands in the violation as the first precept against taking life. What I understood mostly while conducting ethnography is that the notion of morality is often balanced with the social and economical constraint that leads people to provide or to seek abortion. But, for example, in the case of the user, some women said, yeah, it is not good for me to have an abortion, but it is worse if I give birth to a child and I cannot feed him properly, give him medication. So the woman, they balance. What happened from the care abortion side, some of them actually were not so easy in providing abortion, and some of them sometimes wanted even to stop their activities. And it came out in one of the organizations with which I was working, is that the organization's coordinator thought that maybe they need to implement counseling activities for their staff to be able for them to balance their feeling, because they were very much like, oh, it is not good because it is against the Buddha principle, but in other hand, I am providing good services for women, they will not go in another place, so it was really a work to balance that. But another issue has to be mentioned in the delay of the implementation of safe care services for abortion in Cambodia. And it's really related on how international politics of health impact on the woman's daily life in Cambodia. What we need to know is that in here, 2/3 of the health expenditure are supported by international organizations. In the field of reproductive health and family planning, the United States are the most important donors via the Agency for International Development, USAID. And what has become known as the Mexico City policy and referred as the Global Guide rules by NGOs have had a tremendous impact on reproductive health in Cambodia. Indeed, under this policy, all the organizations who were receiving the USAID fundings were not allowed at all to provide the abortion services. And many organizations working in the field of reproductive health were already implementing family program method and delivery services. But if they had any of the USAID fundings, they could not implement abortion services. And effectively, locally, the international organizations providing abortion were also condemned by the Christian aid organization and forced to close the program. So it has been very, very strong here. So this global guide rule effectively was overturned by Bill Clinton in 1993, then restored by George Bush in 2001, and it is on January 2009 that President Obama lifted the ban on U.S. funding for international groups that perform abortion, promote legalization of the procedure, or provide counseling about termination of pregnancies. So since then only, so that's why very recently, actually, it was really possible for organizations to implement safe abortion services. So before I conclude, I would like to explore my last issue is how poor people reproductive bodies are treated, cared and shaped in order to achieve the MDG 4 and 5 objective. And I would like to recall various ethnographies I made during these last 4 years, particularly in what the developer called the relocation zone, which are the zone where the people living in the city center, it's happened in Phnom-Penh, but in many other cities in Cambodia, are evacuated from the city center and relocated like 50 kilometers far away from Phnom-Penh. And I did the fieldwork in this area. I did not plan actually to work at the beginning on eviction issues, but it's when I work on the clinical trial following patients that finally I follow some people at home and I end up in this area. When I work in vasectomy program, I end up also in that area. So it is through this fieldwork on reproductive issues that I end up there. Alors, in Cambodia, since 1990s, due to urban development strategy, land grabbing and land speculation, poor people are routinely evicted from their living areas. In Phnom-Penh, capital, these persons are sent to resettlement area in the outskirts of the city, where some actions are undertaken by Cambodian government and various organizations. From what I observed, charity organizations distribute rice, cooking utensils or sarong. A Korean Methodist church offers a promise of soul salvation after death. However, in this gray area, sanitation, access to water, to primary healthcare services or to education programs are not available. People suffer from extreme poverty and do not have any opportunity of paid employment. In the village where I conduct research, for example, and according to the own word of my informant, people have been thrown out of the city and left as garbage. They were put it in trucks 15 kilometers away from Phnom-Penh and then supposed to settle something for them here where nothing was done for them. Those zones are also targeted by the MDG 5 actors to reduce the maternal mortality. And effectively, there is two actions. One is to provide the vasectomy program who are effectively implemented there, and I explain you how it is done sometimes on what I observe. Another one is to distribute coupon access for free and safe and abortion services and delivery services. But those coupons are not easily used by the people I met, as mostly they have the coupon to get access to services, but they don't have money to pay the transport to go to the services. And some of the women I met, they prefer to sell the free coupon to others that were not aware of the program. So those ethnographic data, which are very short, but I have no time to details, are relevant to examine the local impact and effect of global health imperative. It leads to examine, to analyze how MDG 5 initiatives create new identities, especially as we saw in the professional field, and to describe the local reappropriation of development and biomedical things. My last argument with this ethnography I conducted in this deserved area is that the MDG goal in such context, in the context or in the very deserved context, create a new kind of human. In those studies conducted, reducing the maternal mortality rate among poor people without caring of the social and political conditions that lead them to poverty leads to the following situation. The woman targeted by the MDG 5 initiative, that we will call here the MDG 5 woman, is certainly poor, not educated, but she do not die anymore during procreative events. She can produce baby or abort safely, whatever the violence and the inhumanity of her daily life. Her male counterpart, the MDG5 man, can die of alcoholism, depression, or from any other disease related to extreme poverty, but he is not anymore seen as the indirect responsible of maternal mortality rate. He is made, framed as the agent of positive change, actively participating in the biomedical improvement of reproduction processes. This example of MDG5 implementation presents, as I told in the introduction, the moral economies of contemporary societies that contribute to organize the transformation of poor and troublesome bodies for local development to allowable and rightful reproductive bodies produced by public health imperative. So I argue that the public health objective, which stands behind the MDG5 implementation in the very deserved area, has been analyzed as a mode of classification of human suffering that define what is tolerable or not. From this perspective, maternal death, that is measured with a variety of indicators compared to international norm, is declared not acceptable. Meanwhile, little thought is given to the underlying cause of maternal mortality as the structural violence, inequalities, inequities, which are much more difficult to monitor and to denounce. So it is really the point I wanted to make. It is how now, first, health is becoming as a way of governance, and how reproductive bodies are only targeted as such, not as human, but as reproductive bodies in such circumstances. So it's very interesting because for anthropology of health, it raises many questions on how biomedicine creates new kind of humans, and it has been described, for example, by Paul Rabinow in describing these issues of biosocialities, which is how the biomedicine organizes new kind of individualities and societies. And here, for the theoretical but also, I guess, for political things, but on the research perspective, it's very interesting at this point, because we can see many things, I think, on malaria issues with people who are given drugs, etc., only to protect themselves from malaria, but not for any other things, and never on the global context that frame their daily life. So it's really how the biomedicine create new kinds of human. It is really the point I wanted to make. But there is another issue, is that the global crisis and the construction of new biosocialities, maybe, effectively, after decades of limitation in donors' involvement and activities implementation in the field of maternal health, recently under the MDG5, so it was defined as a priority. But this impact of the MDG5 initiative may be limited. Firstly, WHO representative agreed that between 1990 and 2010, effectively, the global health maternality ratio has declined, but it has declined only by 3.1% per year, and it was not, and it is far from the goal, which was to decline from 5.5% required to achieve the MDG 5. And additionally, since the 2005 financial crisis, various international public health compromises are now being reviewed. The IMF World Bank report dated April 2009 states the global financial crisis is impairing attainment of the 2015 Millennium Development Goals and creating an emergency for development. Most of the 8 globally agreed goals are unlikely to be met, including those related to hunger, child and maternal mortality, education, progress in combating HIV/AIDS, malaria, and other major diseases. So we wonder, in such context, where effectively international funds can start to decline in somehow, in some issues, and this is why we've survived, how activities and people employed to implement and targeted persons supposed to benefit, how it will be reshaped in the context of environmental, political, economical crises. What about the future of abortion providers, vasectomy motivators, rejected unpaid traditional birth attendants, trade unpaid wives? What about poor women and their partner no longer supported at least as reproductive bodies? And may those configurations contribute again to the emergence of what we call the new biosocialities? So it is my last question. So thank you. So it's open for questions.
Relating to what you said about abortion being sensitive. I'm just thinking back to some interviews you've done recently.
Chris, can you speak up?
Oh, yes, please. Yeah.
I'm an old man, but
Yeah.
just thinking about your comment about abortion being a sensitive issue in Cambodia. I'm just thinking about some interviews that we conducted with Mary Stoke Clyde recently. Almost seems to me there are two groups. Ones in whom they can talk more freely about abortion and have disclosed it, and another group where more sensitive. And that perhaps the group that disclosed it more may be married or established relationship, and then you've got a group of unmarried or entertainment workers or students. It seems to me maybe the issue is not abortion being sensitive, but kind of sex before marriage or pregnancy before marriage. So I just wondered if you had any comments.
Oh, yeah, effectively, among this group of population, when I did the field work in karaokes and massage parlors here, I discussed with many young women involved in sex work, and their rate of abortion was at some time, one girl 55 years old, already 5 abortions, so they use a lot abortion method, particular pill, but also surgical method as family planning methods for many reasons. I published on that already, maybe I can forward you the paper, but for many reasons, in fact, abortion is used as family planning method here. But also I discussed with the married women who were not disclosed their choice of having an abortion to their husband, because they felt that the husband, mostly they wanted to have many children, it was great for them, but mostly the woman herself, she has to deal with having this child, and they decide that, so sometimes they got abortion without doing and this is actually not really, on the side of the user, it is really not related to the principle of Buddha, actually. And it came much more, I think, on the provider perspective, these issues. A person, for example, I discussed with Melissa, for example, from Marisop, and she told me that the Marisop trained many people in providing abortion, but many after the training do not provide abortion. They could make a lot of money with that, but they do not provide abortion. And caregiver, they say, oh yeah, now I provide a lot of abortion, I would like to stop, but if I ask that to my boss, I know that I have been recruited to do all the services in my organization. Abortion is one part of the services. If I do not provide, maybe I will lose my job. So it is really an issue to be discussed with teams. Yeah.
I would like to come to a question of what is our future research agenda? How can we help to improve a holistic approach to maternal newborn reproductive health? But before coming to that question, if I may comment, you made a very nice presentation of the whole process of safe motherhood, and you also referred to my article. I'm Derek Liljestrand, so I published a paper.
Oh yeah, okay. Oh, nice to meet you. Yeah.
If we look at maternal health, Cambodia has gone through a very dramatic development. From the maternal mortality ratio in 2000 and 2005, it comes down, and it comes down to a large extent thanks to the total change of the practice of birth. Since the beginning of time in this country, births have been at home.